Valvular heart diseases. Scheme for left-sided valvular heart diseases. We have MSASMR-AR, S stenosis, R regurg. For 4 kinds, we have rheumatic, which is the most common cause, congenital, collagen diseases, SLE, and rheumatoid arthritis, and we have relative or functional. Then, for MS, mitral stenosis, we have Carey-Combe murmur, Austin-Flint murmur, aortic stenosis, calcification, and idiopathic hypertrophic subaortic stenosis, mitral regurg, mitral prolapse, papillary muscle dysfunction, aortic regurg, cephalus, and dissecting aorta. Hemodynamics, left atrial pressure increases, pulmonary congestion, pulmonary hypertension, right-sided heart failure late, left-sided heart failure late, in all except mitral stenosis. In general, any stenosis leads to pressure overload on the upstream cardiac chamber, whereas regurgitation leads to volume overload. Clinical picture of hemodynamics plus MS, we have 4 stages: increased left atrial pressure, pulmonary congestion, pulmonary hypertension, and right-sided heart failure. For aortic stenosis, we have syncope. Any aorta, stenosis, or regurgitation, we have angina. Any regurg, aortic or mitral, we have palpitation and general throbbing. Aortic regurgitation, we have peripheral signs of aortic regurg, which are 9 signs. Cardiac examination, inspection and palpation. Apex, for MS, slapping apex. AS, sustained apex. AR and MR, hyperdynamic apex. So mitral stenosis slapping, aortic stenosis sustained, any regurg, hyperdynamic apex. Pulsation in the second left intercostal space by appearance of pulmonary hypertension. Signs of ventricular enlargement are late and no left ventricular enlargement in mitral stenosis. Percussion, dullness in the second left intercostal space in pulmonary hypertension. Auscultation, normal heart sounds. S1 is increased in mitral stenosis and decreased in mitral regurg. S2, pulmonary component may be accentuated due to pulmonary hypertension. Additional sounds, ejection click due to pulmonary hypertension, gallop due to heart failure, opening snap in mitral stenosis, murmur. Ejection systolic, aortic stenosis, pan-systolic, mitral regurg, early diastolic, aortic regurg, mid-diastolic, mitral stenosis. Complications, we have 12, 3 for valves, 3 for left atrium, 3 in the lung, 2 failure and complications of surgery. Calcification, rheumatic activity, infective endocarditis, rare in mitral stenosis, arrhythmia, AF in cases of mitral stenosis with heart block in calcified aortic stenosis, and finally thromboembolism, stroke. Left atrium enlargement leads to compression on the lung, dyspnea and cough, esophagus, dysphagia, and left recurrent laryngeal nerve leading to hoarseness of voice. 3 lung, pulmonary congestion, hemoptysis, recurrent chest infections, pulmonary infection, pulmonary embolism secondary to DVT. Right-sided heart failure, left-sided heart failure except in mitral stenosis. Complications of surgery, artificial valves lead to mechanical dysfunction, infective endocarditis, thromboembolism, and hemolytic anemia. Investigations, X-ray, chamber enlargement and pulmonary congestion. ECG, chamber enlargement, left atrium, we have P mitral, M-shaped P wave, pulmonary hypertension, P pulmonal, peaked P wave. Echo and Doppler, this is the most important, chamber enlargement and detect severity of valve lesion. Catheterization and angiography for severity and chamber enlargement. Treatment, medical and curative, medical prophylaxis against infective endocarditis and rheumatic activity, and treatment for complications, whether heart failure, atrial fibrillation, or infections. Curative, balloon dilatation, percutaneous balloon valvoplasty for stenosis, especially pure mitral stenosis, valvotomy, commissurotomy for stenosis, and finally valve replacement, tissue or synthetic valves. Mitral stenosis, anatomy of the mitral valve, side between the left atria and the left ventricle, surface area 4 to 5 cm square. If less than 1 cm square, this means tight mitral stenosis. Shape of mitral orifice, rounded or oval during diastole and slit-like during systole. Its axis downward, forward to the left. Components, fibrous ring, 2 cusps, anteromedial and posterolateral. 2 papillary muscle from the ventricle to control cusp movement. Chordae tendini arise from papillary muscles to both cusps. Etiology: it's narrowing of the mitral valve less than 2.5 centimeters square. We have rheumatic heart diseases, which is the commonest cause, more common in females, occurs years after original attack and usually associated with multivalvular lesion. Congenital Luttenbacher syndrome, which is atrial septal defect plus mitral stenosis or parachute mitral valve. Relative or functional Carey-Combs murmur, acute stage rheumatic fever leads to its occurrence due to edema of the cusps, leading to transient narrowing of the mitral valve. Austin-Flint murmur, murmur of mitral stenosis and severe aortic regurg. The regurged blood during diastole interferes with the opening of the mitral valve. Conditions which lead to increased blood flow through the mitral valve, such as VSD, ventricular septal defect, PDA, and mitral regurg. Hemodynamics: increased pressure in the left atrium with dilatation, back pressure on pulmonary vein leading to pulmonary congestion, leading to pulmonary hypertension, leading to right-sided heart failure, but never left ventricular enlargement or left-sided heart failure. Mechanism of pulmonary hypertension: we have passive pulmonary hypertension, constrictive reactive pulmonary hypertension, obstructive pulmonary hypertension, and acute obstructive pulmonary hypertension. Constrictive or reactive pulmonary hypertension, long-standing congestion, leads to reflex vasoconstriction of pulmonary arterioles to relieve the congestion, but this leads to development of hypertension. Obstructive long-standing vasoconstriction leads to irreversible narrowing of the arterioles. Acute obstructive, such as pulmonary embolism. Clinical picture: stage 1 asymptomatic, just increase in left atrium pressure. Stage 2 manifestations of pulmonary congestion, dyspnea, P edema, pulmonary edema is not common. Stage 3 manifestations of pulmonary hypertension, low cardiac output, Mallory giant A wave. Stage 4 manifestations of right-sided heart failure, low cardiac output, and systemic congestion. Cardiac examinations, inspection and palpation: we have slapping apex, weak impulse due to decreased left ventricle filling with palpable S1 due to accentuated S1, apical diastolic thrill. Stage 3, we have pulsation and systolic thrill in the second left intercostal space with palpable S2 due to pulmonary hypertension. Percussion: stage 3, dullness in the second left intercostal space due to pulmonary hypertension. Auscultation: normal heart sounds, accentuated S1. The stenotic valve has to open as wide as possible to overcome this stenosis, leading to closure of mitral cusp from lower position. This accentuates S1. The more the accentuation, the more the stenosis. Causes of weak S1 and mitral stenosis is calcification or associated mitral regurg. S2 normal but may be accentuated in stage 3 due to pulmonary hypertension. Additional sounds: opening, snap, sharp snapping sound following S2 due to sudden opening of the rigid cusps. The closer the snap to S2, the more the stenosis. Calcification causes disappearance of the opening snap. Ejection click in stage 3 due to pulmonary hypertension. Gallop on tricuspid area. This occurs in stage 4 due to right-sided heart failure. Then murmur: we comment on script, site, character, relation, intensity, propagation, and timing. Site: best heard at or inside the apex. Character: rumbling, low-pitched murmur. Relation to respiration and position: increases with expiration and increases in left lateral position because it's left-sided murmur, while if it's right-sided heart murmur, it gets louder on inspiration. Intensity: pre-systolic accentuation due to atrial contraction, and pre-systolic murmur is absent in atrial fibrillation. Propagation: no propagation is localized. Timing: mid-diastolic, pre-systolic. Silent mitral stenosis: decreased blood flow through the mitral valve leads to no murmur, and this occurs in associated ASD, atrial septal defect, Luttenbacher syndrome. Low left atrium pressure, severe pulmonary hypertension or right-sided heart failure, or high left ventricle pressure, left-sided heart failure. Stage 3, ejection systolic murmur of pulmonary hypertension. Stage 4, pansystolic murmur due to of relative tricuspid regurg. Investigations: X-ray, left atrium enlargement, lateral view with barium, pulmonary congestion, dilated pulmonary artery, right ventricular enlargement, calcification of mitral valve. ECG, arrhythmia, pulmonary hypertension, P pulmonale, peaked P wave, left atrium enlargement, P mitral, M-shaped P wave, right ventricle enlargement in late stage. Echo and echo Doppler chamber enlargement, valve lesion, calcification, catheterization and angiography, chamber enlargement, mitral stenosis index, cardiac output over left atrium pressure, times 100, 5 over 5 times 100, it's usually 100%. If less than 25%, then this means tight mitral stenosis. Complications as scheme: treatment, medical and surgical. Medical prophylaxis against infective endocarditis, rheumatic activity, treatment of the complications, blah blah blah. Surgical, not very early, not very late. Balloon dilatation in pure mitral stenosis, no calcification, not combined with mitral regurg and not severe. Valvotomy or commissurotomy. Number 3, valve replacement, tissue or synthetic valves. Indications for replacement: calcification, associated mitral regurg, tight mitral stenosis when surface area is less than 1 centimeter square, or with severe manifestations, or with MS index less than 25%. Recurrent stenosis after balloon dilatation or valvotomy. Then we have mitral regurg or mitral insufficiency. Etiology: rheumatic, the most common, congenital, collagen diseases, infective endocarditis, surgical, mitral valve prolapse, papillary muscle dysfunction, and myocardial infarction and Marfan syndrome. Functional or relative from dilatation of mitral ring due to dilatation of left ventricle in left-sided heart failure and aortic regurg. Hemodynamics: during systole, part of blood regurgitates from left ventricle to left atrium, leading to left atrium dilatation. During diastole, increased blood flow through the mitral valve increases the volume overload on the left ventricle, so the left ventricle enlarges and then fails. In acute mitral regurg, as in myocardial infarction and infective endocarditis, left atrium has no time to dilate and accommodate the regurgitant blood. So this leads to great increase of left atrium pressure, leading to rapid pulmonary congestion, rapid pulmonary edema, which can lead to cardiogenic shock. Clinical picture: asymptomatic for many years in mild cases, palpitation, general throbbing due to left ventricular volume overload, manifestations of left-sided heart failure, which is late, manifestations of pulmonary congestion, then pulmonary hypertension, then right-sided heart failure, which is later than the left-sided heart failure, and finally acute pulmonary edema in a case of acute mitral regurg. Cardiac examination, inspection and palpation: left ventricular enlargement, hyperdynamic apex, forcible non-stained apex, systolic thrill over the apex. Auscultation: normal heart sounds. S1 is weak. S2 may be accentuated with development of pulmonary hypertension. S1 is weak due to weak closure of the mitral valves and masking by pansystolic murmur of the mitral regurg. Additional sounds with heart failure: gallop with pulmonary hypertension, ejection click, murmur of mitral regurg, site, best heard at the apex, character, blowing, relation to respiration and position, increases with expiration and increases in left lateral position, propagation to axilla except in posterior leaflet regurg, it radiates to the base of the heart and best heard from the back, timing, pansystolic murmur, plateau, relative mitral stenosis, mid-diastolic murmur due to excess blood flow across the mitral valve. Complications as scheme: investigations, X-ray, echo, ECG, catheterization. X-ray as in mitral stenosis plus left ventricular dilatation. ECG, chamber enlargement and arrhythmia. Echo, chamber enlargement and valvular lesion, as well as the catheterization. Treatment: medical as scheme, surgical, valve replacement or mitral valve repair. Then we have mitral valve prolapse. Definition: prolapse of one or both cusps of the mitral valve into left atrium during systole. Etiology: idiopathic, in most cases more common in young females. Connective tissue diseases: Marfan syndrome, Ehlers-Danlos syndrome, systemic lupus erythematosus, polyarthritis nodosa, and finally muscle disorders: Duchenne myopathy, myotonia dystrophy, congenital heart diseases, ASD, acquired heart diseases, myocardial infarction, post-mitral valve surgery. Clinical picture: asymptomatic in most cases. Atypical chest pain is the most common symptom, usually left submammary stabbing. Sometimes it's severe substernal aching pain, palpitation due to abnormal ventricular contraction and arrhythmia, fainting and syncope, sudden death due to fatal ventricular arrhythmia, which is very rare. Cardiac examination: the most common sign is mid-systolic click, which is produced by sudden prolapse of the valve during systole and the tension of the chordae tendineae. This may be followed by late systolic murmur due to some regurgitation. With more regurgitation, the murmur becomes pansystolic. Investigations: echo is diagnostic. Treatment: reassurance, prophylaxis against subacute infective endocarditis, beta blocker, propranolol, and valve replacement in severe cases. Aortic stenosis. Anatomy: 3 semilunar cusps attached to fibrous valve ring. In about 1% of individuals, only 2 cusps are present. Bicuspid aortic valve, and the surface area is about 3 cm square. Etiology: rheumatic fever congenital, which may be valvular, subvalvular, supravalvular. Classifications: hypertrophic cardiomyopathy or idiopathic hypertrophic subaortic stenosis, IHSS. Relative: increased blood flow across the aortic valve due to aortic regurgitation or dilatation of aorta, hypertension, and atherosclerosis. Hemodynamics: during systole, there is obstruction of left ventricle outflow leading to low cardiac output symptoms and pressure overload on the left ventricle leading to left ventricle hypertrophy and failure. Clinical picture: asymptomatic in mild cases, manifestations of low cardiac output, syncope, especially exertional due to low fixed cardiac output, angina due to low cardiac output leading to decreased coronary blood flow, left ventricular hypertrophy increases oxygen demands, and associated atherosclerosis or aortic regurg. Manifestations of left-sided heart failure. Cardiac examination: left ventricular enlargement, sustained apex, forcible and sustained, systolic thrill over the second right intercostal space A1 propagated to the apex and neck. Auscultation: weak S2 with closed, single, or paradoxical splitting, delayed aortic component. Additional sound: ejection click due to opening of rigid aortic cusp, disappears with calcification. Gallop due to left-sided heart failure. S4 due to pressure overload on the left ventricle. Murmur of aortic stenosis. Site: maximum over A1 area, second right intercostal space. Character: harsh, but may be soft in relative to aortic stenosis. Relative to aortic regurg. Relation to respiration and position: increases with expiration and leaning forwards. Propagation: neck, carotid arteries, and apex. Timing: ejection, mid-systolic murmur, diamond-shaped crescendo decrescendo. Murmur of functional mitral regurg due to dilated left ventricle, leads to pansystolic murmur on the apex. Complications: C-scheme. Investigations: X-ray, left ventricular enlargement, pulmonary congestion. Calcification: post-stenotic dilatation in valvular type. ECG: left ventricular enlargement. Echo detects the severity of valve lesion. If less than 0.8 cm square, this means severe aortic stenosis. And finally, chamber enlargement. Catheterization detects the severity as it can measure the pressure gradient across the aortic valve. Treatment: we have medical treatment, same as scheme, plus beta blockers for angina, surgical, aortic valve replacement and balloon dilatation, and aortic valvotomy. And this is associated with high early restenosis rate. Aortic valve replacement indications are valve area less than 0.8 cm square, severe symptoms, systolic pressure gradient across the aortic valve more than 50 mm mercury. Aortic regurg. Etiology: rheumatic fever congenital, infective endocarditis, surgical, dilatation of the ascending aorta due to syphilis, aortic dissection, ankylosing spondylitis, Marfan, severe hypertension. Hemodynamics: during diastole, regurgitation of blood from aorta to the left ventricle leads to volume overload on the left ventricle, left ventricular failure, enlargement, and decrease in the coronary blood flow, angina, increased blood in left ventricle, increased left ventricular contraction, increased stroke volume, increased systolic pressure. The high systolic blood pressure is compensated by peripheral vasodilatation, which together with regurgitation will decrease the diastolic blood pressure. So in aortic regurgitation, there is increased systolic blood pressure due to high stroke volume, high cardiac output, and decreased diastolic blood pressure due to peripheral vasodilatation and regurgitation of the blood during diastole. And that's why we have big pulse volume in the examination. Clinical picture: asymptomatic in mild cases, general throbbing due to increased arterial pulsation, palpitation due to forcible left ventricular contraction. Angina: we have two types, classical and angina of Lewis. Classical due to decreased diastolic blood pressure, decreased coronary blood flow, left ventricular enlargement leads to increased oxygen demands, angina of Lewis, nocturnal prolonged angina associated with autonomic disturbances such as sweating and tachycardia. Manifestations of left-sided heart failure, pulmonary congestion, and low cardiac output. Peripheral signs of aortic regurgitation due to big pulse volume. We have 3 in neck, 3 in upper limb, 3 in lower limb. Head and neck, Demusset sign, nodding of the head, Corrigan's sign, marked visible carotid pulsation, systolic thrill over the carotid artery. Upper limb, blood pressure, increased systolic and decreased diastolic blood pressure, pulse, water hammer pulse, capillary pulsations, pressing on the nail tip. We have moving red line. Lower limb, pistol shot, systolic femoral sound due to sudden distension of collapsed artery. Durosier's sign, systolic and diastolic murmur over the femoral artery if slight pressure is applied by the stethoscope. Hill's sign, the difference between systolic blood pressure in the lower limb and upper limb exceeds 50 mm mercury. Normally, it's from 10 to 20 mm mercury. Aortic regurg with minimal peripheral signs due to mild aortic regurg, decreased systolic pressure as in mitral stenosis or aortic stenosis, or increased diastolic blood pressure as in systemic hypertension. Cardiac examination, left ventricular enlargement, hyperdynamic apex, no thrill over the aortic area in isolated aortic regurg. Auscultation, S2, usually normal in isolated aortic regurg. Additional sounds, gallop on the mitral area, murmur of aortic regurg site, maximum over the third left intercostal space, A2 area. Encephalitic aortic regurg, its maximum over A1 second intercostal space. Character, soft, blowing, decrescendo, relation to respiration and position, increase with expiration and leaning forwards. Propagation to the apex and left sternal border. Timing, early diastolic. Murmur of relative aortic stenosis, ejection systolic murmur, soft. Murmurs over the mitral area or apex in case of aortic regurg. Mid-diastolic murmur of relative mitral stenosis, Austin Flint murmur. Pansystolic murmur of relative mitral regurg. Propagation of ejection systolic murmur of relative or combined aortic stenosis, and the propagation of early diastolic murmur of aortic regurg itself. Complications as scheme. Investigations, X-ray, left ventricular enlargement and dilated aorta, boat-shaped heart. ECG, we have left ventricular enlargement. Echo, left ventricular enlargement, detects severity of the valve lesion as well as catheterization. Treatment, medical as scheme. Surgical, valve replacement in severe organic cases with left ventricular dysfunction. Then we have comparison between rheumatic and syphilitic aortic regurg. Rheumatic aortic regurg, it occurs from 20 to 40 years of age. History of rheumatic fever with positive valvular lesion, less commonly to have angina. S2 is usually normal. Murmur with maximum intensity over A2, and X-ray we have calcifications. While in syphilitic aortic regurg, it occurs in age more than 40 years. History of syphilis, no valvular lesion. Angina is more common. S2 is accentuated. Murmur with maximum intensity is heard over A1. And finally, X-ray, we have aortic aneurysm. Tricuspid stenosis, etiology, it's usually rheumatic in origin and associated with mitral or aortic valve lesions. Hemodynamics, obstruction of the tricuspid valve leads to increased right atrial pressure, right atrial enlargement, systemic congestion, decreased right ventricle filling, decreased cardiac output. So the clinical picture is symptoms of low cardiac output, symptoms of systemic congestion, system of associated lesions such as mitral stenosis. Tricuspid stenosis decreases the symptoms of mitral stenosis due to restriction of pulmonary flow. General signs, low cardiac output, systemic congestion, neck vein, giant A wave. Cardiac sign, right atrial and right ventricular enlargement, mid-diastolic, pre-systolic murmur. At lower left sternal border, increased by inspiration. Investigations, X-ray, ECG, right atrium and ventricle enlargement, echo and catheterization are diagnostic. And treatment is valve replacement. Tricuspid regurg, TR is usually functional, resulting from right ventricular enlargement, dilatation of tricuspid ring. Hemodynamics, during systole, Part of the blood regurgitates from right ventricle to right atrium, leading to increased pressure of the right atrium, right atrial enlargement, and finally systemic congestion. Low cardiac output, right ventricular enlargement, and even failure. Clinical picture of cause: systemic congestion, low cardiac output symptoms, general signs of systemic congestion: congested pulsating neck vein with systolic expansion, enlarged tender pulsating liver with mild jaundice, ascites before lower limb edema. Signs of low cardiac output: cold hand, weak pulse, decreased systolic blood pressure, peripheral cyanosis, mild jaundice, liver congestion with peripheral cyanosis equals cyanoicteric phase. Cardiac signs: right atrium and ventricle enlargement, systolic thrill over tricuspid area, murmur, pansystolic murmur increased by respiration, maximum over tricuspid area, propagated to the apex but not to axilla. Complications: right-sided heart failure, infective endocarditis, cardiac cirrhosis. Investigations: X-ray and ECG, right atrium and ventricle enlargement. Echo and catheterizations are diagnostic. Treatment of the right-sided heart failure, and valve replacement. Then we have important differential diagnosis. Differential diagnosis of systolic murmurs: aortic stenosis, pulmonary stenosis, mitral regurg, tricuspid regurg, VSD, PDA, coarctation of the aorta. Over apex, mitral regurg propagated from other area, we have all of the mentioned lesions propagate to the apex. Over the base, all except mitral regurg and tricuspid regurg, they don't propagate to the base. Except for posterior leaflet mitral regurg, it may propagate to the base. Differential diagnosis of diastolic murmur: aortic regurg, pulmonary regurg, mitral stenosis, tricuspid stenosis, PDA, and coarctation of aorta. Over the apex, mitral stenosis, whether organic or relative, propagated from other areas such as aortic regurg and pulmonary regurg. Over the base, we have aortic regurg, pulmonary regurg, PDA, coarctation of aorta due to collaterals. And this concludes our chapter for today.